Yeah. Hello again. How are you? I think you're muted.
Hi, how are you?
Thank you for coming back.
Of course. I like your purple rain picture in the back.
Oh, thank you.
So I'm going to use a new type of presentation software, which is internet-based. I really hope it's going to work out. I just wanted to refresh the audience, uh, like from typical PowerPoint presentation. So let's see if it works. I'll try to share my screen, and you tell me um, if you see that.
Yeah, we see it.
Do you see a full screen here as well, or just my sort of screen? Do you see a full screen now?
Yeah, we do see a full screen.
Okay. And what about now? Do you see that screen as well?
Yeah.
Okay, perfect. So let's just wait another second and I'll. All right, Queen, you tell me when you want me to start.
You can get started. Yeah.
Okay. All right, so hi everyone. Well, today is going to be a little bit of a different concept of presentation. Both the modality, I'm using this internet software that I thought is refreshing, and just bear with me if there are any internet issues here. Hopefully it's going to go smooth and nice. And also the topic of today is, I would say, a very interesting topic because it summarizes a lot of the things that you already heard. So it will give you, I think, like a good recap and overview of many of the things that you learned so far, but also open your imagination and hopefully will get you engaged in some cool futuristic applications in neurosurgery, as well as get you excited about how we educate our residents and medical students. There are a lot of cool new technologies to assist us in medical educations, both for medical students, for residents, and even attending and educating patients as well. So I'll try to share all of that in 1 hour. We'll leave some questions in the end, but this is, I think, a good overview of our field. So let's start. So obviously we're going to talk about the brain today, and just to kind of put things out there, brain disease is a problem. We talk about the heart and we talk about MIs and infarct, but when you look at the numbers of brain diseases, we have more than 700,000 strokes a year. 85,000 patients will be diagnosed every year with brain tumors, and 1.5 million people will have traumatic brain injury in every year. If you think about those numbers, those are huge. This is a real problem. And, we're trying in the past decade to expand our knowledge and research efforts on the brain. And they call it the brain era and the brain decade because a lot of resources being, directed into brain health, promoting awareness, and treating diseases. We're going to talk about today, a few things. One is how do we acquire information? How do we learn about the unknown and specifically how we learn not to hurt it, and what are some of the solutions we have to integrate all that knowledge, including educational efforts, into our patients. So, so this is a case. This young guy or a girl coming to the ED with headaches. You scan them, you have a CT, and you see this blood in the posterior left temporal area of their brain. And you ask yourself, what is that? So luckily enough, we have CTs, CT started to be mainstream in the 70s. But what else can we know about this, lesion? Is it just bleeding? Is it a tumor? What tracts are being involved? What areas are being affected? And you'll see towards, this presentation, how we can gain more and more information from our technologies. And this is what I call data acquisition. So we did the CAT scan, but then back in, in the 80s, this new machine called the MRI started to get, more popular, giving us much better, higher definition images of the brain. And all of a sudden here, compare the CT to the MRI on the right side, you see that we're gaining much more information. We can see the gray matter, we can see the white matter, we can see the vessels in the sylvian area, we can see this edema surrounding this, the blood, and we can actually see that inside the, this lesion, there are some irregularly shaped lesion that is likely some occupying lesion. So then we know that this area is a critical area for language. So we can now do functional MRI. The patients go into the MRI machine and they're getting tasks like reading, counting, thinking about things. And using this bold sequence, we'll see how the information or actually what areas of the brain are getting lightened by those colors that are related to the oxygen delivered into the area according to the task performed, which tells us that all those pinkish or whatnot, like orange, yellow type of areas are related to speech areas. So we see the lesion here, and you see that there is a speech area just above it. And, Dr. Silverstein talked to you before about how you monitor spine surgery, but we can definitely monitor speech and craniotomy surgeries for various type of lesions. Then we can add another layer of information. It's called DI, or tractography, which basically paints all those different tracts surrounding the tumor to help us with the trajectory and how we can avoid certain important tract going into the lesion. And this day, we're using here at Lenox-Hill very new kind of artificial intelligence, device or machine called Omniscient, which is basically an AI-based software that taking all the functional information and painting the brain with parcellations, right? So all those different dots and all the different squares and wires essentially give us information about functional connectomics. When we're doing surgery now, we're talking about connectomes, not necessarily anatomical, traditional anatomical areas like Broca's, like Wernicke. We actually shifting our conversation into speaking about connectomics. We know that the brain is an organ that's full of lots of different wires connected to each other called connectomes. So those networks are what we're operating on, and this software gives us a pretty accurate image of those networks surrounding the tumor. Another pretty cool and exciting technology is virtual reality. So this software is segmenting areas of the brain according to images. So this is a CTA and an MRI, and we can fly through the brain and look at the vascular anatomy of this MCA aneurysm and learn the 3D architecture of the lesion to be better prepared when you come back to the surgery. And I'll show you some other applications of the software. Now, we have to learn everything about those things, right? What tests we want to ask for. What are those modalities gives us? What type of information can we get? How do we utilize this information? And very early in our training, from med school to residency, the way I see, the education right now is composed of 5 different components: theoretical, clinical, surgical, professional, and personal growth. And I'll go over a little bit. So theoretical, basically what you guys are doing in this summer camp or this brain turn internship is theoretical knowledge. You listen to lectures, you're reading the notes, you're reading the books to learn about the brain. For us in the hospital, we're having grand rounds when we have guest speakers coming to talk about their fields of expertise. We have residents preparing cases, anatomy, pathology, microsurgery techniques. We're doing away rotations where we can go to different hospitals that have expertise in certain areas, like let's say functional neurosurgery or neuroplastic surgery, which are not mainstream everywhere. You can decide to choose to go and learn more in away rotations, and research fellowships, which you can expand your knowledge by doing research with, in certain area that you're interested in. The second tier is clinical, right? Nobody can learn how to treat patients just from reading a book, same as nobody can learn how to play tennis from reading a book. And this book about peak performance is pretty popular, talking about the 10,000 hours to mastery. During the residency, we're having a lot of hours in the hospital, in the ORs, in the emergency room, in the ICU, treating patients to actually get our clinical and hands wet within patients' issues. But as you see in bold, good teaching matters, not just practice, meaning that if you just come in the morning and don't do your proactive teaching, and you don't go home and read about cases before and after the cases, you're not getting the maximal effect of learning. Then when it comes to surgical manual, we have, as I said, augmented and virtual reality, when you can wear those goggles and fly through a patient's brain and learn the specific anatomy of the lesion in relationship to other eloquent area of the brain. We have those fancy labs with microscope and those phantoms, which you see on the right upper image, which are very good simulation material that will help us prepare for surgeries on a phantom before we go into a patient. And one thing that I think emphasize again and again is mentorship, right? And this is a good quote saying, encourage all of you to seek out teachers and mentors that challenge you to think for yourself and guide you to find your own voice. And this is pretty accurate sentence, at least for what I see is a good mentorship. And you can have several mentors in different areas in your journey to help you and challenge your thinking and guide you how to have your own opinion. Another thing that is very critical when it comes to mentorship is your mentors should guide your eyes off. And eyes off is the ultimate zone of optimal function. And this term came from sports psychology, which essentially say that different people have different zones of optimal performance, right? Some athletes or surgeons, best performance is when their arousal is low, they're in this meditative state, everything is calm, and this is where they function the best. On the other spectrum is people like myself that function the best when the stakes are high, when the risks are high, and then when the arousal are high. So you know, people like me, and I learned it with the years, function the best under pressure. Now, don't forget that arousal and pressure has this bell-shaped curve. Your optimal arousal, should be in the top of your strongest performance. If you're too aroused or too stressed, your performance decrease. And this is yourself and your mentor's goals to sort of gauge you to which type of eyes of you are. Are you at your best when you're in a quiet, non-stressful environment? Or are you at your best when you are in a very high stakes, stressful environment? And one message that I always try to convey about education is humility. As brain surgeons, and we all know that in residence, we have a lot of ego, right? We are thinking that we are the best and we can do everything. But with time and experience, we always have to remind ourselves that we have to be humble and really think about patients first before we go out to tell the world that we are superstar neurosurgeons. And this Dunning-Kruger effect actually describes that. There is a pretty critical relationship between confidence and competence. And it's pretty easily described here, right? When we just starting and rookies, we don't know anything. Our confidence is so high. We just made it through med school, we got into the training, or we just made it through high school, we got into the med school, and we feel at our best. We feel that we are the best. But this is also our Mr. Stupid, because when you're just starting out, you know nothing. And then with time and with good amount of hours and sleep deprivation and food deprivation, we start to think this is actually harder than we thought it's going to be. And this is actually when our confidence is starting to go down, but our competence is starting to increase. And the third emoji here, I'm never going to figure this out, is something that everybody can relate to. You're in this certain phase of learning when you're so overwhelmed that you're thinking to yourself, I'm never going to make that. And this is what's called the valley of despair. But don't forget that you push through the pain, you come in every morning, you go on brain turns very early and stay very late, and slowly you increase your competence. And after some time, when you increase your competence, you're gauging from a rookie to an expert level, starting to figure things out until you feel like really good and your competence and confidence align, which I must say in neurosurgery, as much as this guy is dangerous, also this guy is pretty well dangerous. You really have to be humble and debrief for yourself after each and every case what you could have done better. And those are good quotes that the father of modern surgery, William Osler. And let me read you those two quotes. To study the phenomenon of disease without books is to sail uncharted sea, while to study books without patients is not to go to sea at all, meaning that you really have to combine both theoretical and practical knowledge. And the value of experience is not in seeing much, but in seeing wisely, meaning that when you get into this expert and competence level and your experience, that's not because you had 1,000 cases under your belt, but you learned wisely from each and every mistake and each and every case you had. And we're doing it on a daily basis. After we've done the case, we go to the microscope footage and we look and figure out how can we do better. And this is just an example of mastery and excelling in surgery. So this is left superior temporal sulcus operation, where you really use your microsurgical techniques not to touch the brain, just to dissect the arachnoid, separating those two gyrus without a little bit of blood, which to get to this level of expertise takes years and years and years and years of preparation. And I find this video beautiful because you can see that when you're a true master, you're treating a brain disease like a little thief. You find those corridors without injuring any vessel or any brain. You find a lesion and you successfully treating it. And as you can see, this little corridor under the microscope revealed the tumor, sucking out the tumor here, bipolaring it from the edges. And soon you'll see how we just remove an end block resection of the tumor without injuring any area of the brain. So with good technology, skills, and experience, we all aiming to have those type of results. Now, when we talk about, how we integrate all this type of technologies into one patient and to one specific time in their life, which they have uh, essentially gave us bravely their life and trusting us with all the knowledge, expertise, and technologies that we have to treat them safely. And this is how our OR at Lenox Hill looks like. We have a navigation system, ultrasound, integrating cockpit, and all those different technologies, which I'll show you in a minute, available to us. So I think you already heard that we have virtual angiography in the OR. Injecting an ICG to patients with our filters can show you essentially an angiogram of the patient's vessel in vascular surgery. We have those dyes like 5-ALA, which fluorescent the diseased brain tumor and help us to separate the tumor from the surrounding brain. We have a navigation system that we can prepare before the case, sit on the system, really learn the anatomy, paint the tumor, figure out our trajectory, and really have a good mental representation of the case before we even touch the patient. So our brain works in a way that it doesn't matter if we actually do the surgery or imagining how we do the surgery, our brain still fires the same signals to our muscles. And this is what's called mental representation or guided visualization. I'm visualizing what I'm going to do, how I'm going to approach my trajectory, and what maneuvers I'm going to do with the tumors and the brain in order to have a safe surgery. And we have an intraoperative ultrasound, which is a very old technology that we're using now inside the OR to show us in real time how the tumor looks like before and after surgery. We have a CAT scan inside our OR that can give us a better information in real time, either in cranial surgery or spine surgery. We have 3D printers that we can print certain parts of the skull that is missing following a resection inside the OR and bend it and mold it and mesh it in a way to give the patient the best reconstruction or best trajectory towards treating the disease. And we have this cockpit, what I call the cockpit, which is a system integrating everything all together in one screen and help us choose the different modalities to look at in real time. I'm sure that you heard about awake craniotomy, parafascicular surgery, as you saw before, and as Dr. D'Amico talked to you about, those tubular retractors that will assist us to go to the lesion without retracting the brain, what's called retractorless surgery, all to avoid injury. And for residents education, these are some of the things that we can use today. Those 3D printed models that can be printed based on patients' real imaging. We have those jelly type of phantoms that are pretty accurate in terms of brain consistency and tissue densities. And you see on the left side how we practice bypass anastomosis on those brain phantoms. On the right side, we practice tumor resection with 5-ALA using the exoscope. So all those things are available to us here at Lenox Hill. I'm very proud to say that we are the cutting edge of neurosurgery in terms of both patient experience and residents and med students education. So this is how, for example, we can plan for a surgery. We can print the patient skull and head and paint it with different colors for the skin, for the bone, for the tumor, and actually prepare the operation inside the real OR with a brain phantom. As I said, the fact that your brain is that your hands are doing the work on a cadaver or a phantom trains your brain to do it on a real patient. So this first mental representation teaches our brain how to do the real surgery. So when we come back to the OR with a live patient, it's like we're doing the same operation for the second time. This is why augmented and virtual reality and 3D printing of the pathology really help us to prepare to those difficult cases. All right. Now I'm going to switch to another case that I want you guys to see that is here on YouTube. Just someone can raise their hand or let me know if you see and hear that. Can you see and hear that?
Yeah.
Okay, good. So this is how we plan a pretty complicated surgery with augmented or virtual reality. As we said, it's a summary CT, MRI, tractography, and functional MRI. And then we took all the information that we had and we gained throughout our preoperative study and putting them together into one 3D virtual reality concept. המערכת של Surgical Theater נותנת לי תמונה ויזואלית והכנה מנטלית הרבה יותר מדויקת לקראת הניתוח עצמו. ואם אני יכול לנתח כבר את החולה פעם אחת וירטואלית, אני ארגיש הרבה יותר טוב עם ביטחון הרבה יותר גבוה להגיע לניתוח האמיתי. So this is in Hebrew, but system translation in the bottom. So this is actually the 3D virtual anatomy of the patient, superficial and deep structure with a lesion. And we plan the trajectory, how to go into the lesion, without injuring the brain. You see the relationship between the different anatomy, vessels, white tracts, all the different language areas and motor speech area. Cortical spinal tracts in green, the tumor in red. The ultrasound inside the OR that will show us exactly that we're above the tumor. Neuronavigation to tell us exactly our trajectory. Going in between the sulcus to find a lesion without injuring the brain. Finding the tumor. And this is the ultrasound in the end to show us the resection cavity. And this is the post-operative finding. Tumor is completely removed. We preserved all the vessels. גם כשהמטופל רואה את המוח שלו עם צבעים, עם צורות תת-מדיות, נותן לו, עוזר לו להבין במרחב איפה הגידול שלו נמצא, עוזר להם להבין יותר טוב מה אנחנו הולכים לעשות. All right, do you see the screen again? Can someone just ping me if they see the screen?
Yeah.
Okay, perfect. So what are we doing after the surgery? Things that we can do now is, and who was, the people of you that were in my lecture about neuroplastic surgery, we can now create those sonal sort of windows, which are essentially those little clear windows that we can ultrasound the brain after surgery, and we can look at the brain just in clinic without the need for CT or an MRI, just by fixating this little clear implant over the brain. So summarizing, I think that what you guys are doing right now and the Brain Turn program is an amazing opportunity, and big shout out to all of you that are listening and spending their summer vacation at home, watching through those lectures morning until noon, and spending and investing in your own knowledge, because this is the best thing that you could probably do for yourself in your future career. So this is a quote that I like, that actually my previous mentor in my residency keep saying all the time, if you act like you're doing what you're doing, you can probably do anything except neurosurgery. And this is pretty true. It's a complex type of pathology and organ, and we can now do a liver transplant and heart transplant and kidney transplant, where we cannot replace the brain. And for obvious reasons, I think that this is why we should all invest in our knowledge and be humble about what we know, continue our research efforts, and questioning ourselves, what is it we can do better? That's it. That's my Instagram and LinkedIn. Feel free to ask any questions. All right, Queen, do you want me to start read the questions, or you want me to?
Yeah, you can start on the questions.
Okay. So what is the name of the navigation system? There are several navigation systems: Medtronic, BrainLab, and Stryker. Can I enter the Valley of Despair early when I study for MCATs? Absolutely yes. Is the fellowship Valley of Despair? Well, I think that every step in your training, you'll have Valley of Despair, where you when you enter your residency, you feel like you know nothing. When you enter your fellowship, you feel like you know nothing. And I think that definitely Valley of Despair is something that we encounter quite many times in our training. How do you see medical education evolving in the future? I think that right now is the future. We are living in, we are very privileged to live at this era where we can not only have an access to an ocean of information online and everything is readily available for us. We can use all those technologies to our training, and I think that right now is probably the best time to live in terms of anything, right? Basically, when you talk about education, when you talk about patient experience, when you talk about surgical outcomes, we're so privileged to have all these technologies available for us, and I think this, it's now we're living in the future right now. Can I come as M1 to Lennoxio? Sure, you can. Dealt with anxiety. How did you manage it? Keep going rather than quitting medicine. Your lecture have been absolutely amazing. Thank you. Alexter Rivera Morales. Hope I pronounce it right. Thank you for your feedback. Basically, you have to push through the pain. You know, you have to know that this is part of the progress, and anxiety and failure is part of the progress, and it's a learning curve. And don't look at failure as a defeat. Just look at it as the opportunity to learn. And it sounds very mundane and like cliche, but you really have to push through the pain and uh, know that all these failures are just feedbacks and reference experience to your career. And if you reframe that anxiety into a learning point, this is how you can make it happen. We have to know that anxiety is normal emotion, fear is normal emotion, and even though society and social media might tell you they need to be happy all the time and uplifted and grateful, sometimes we're not, and it's totally normal to be normal. So this is why I think that dealing with anxiety is or depression or failure is just part of normal human being. and and you should really filter all the background noise. During my training, I heard so many times the word no, and you're not going to make it, and you don't have the whatever it takes. But I had to filter all those. Really, I had to filter all those different, all this background noise, because when you listen to this background noise, it really affects you. And if you want to be something, and if we have a dream and you want to pursue that, you really have to have tunnel vision and laser focus, and really disregard all those different things that you heard, both about yourself and about what you do. And I think this is the way to push through. um, Julie Netkins, residents practice most through their whole first year. When are they allowed to actually perform surgery? Also, do the practices? All right. So basically, about the practical experience, you're getting an experience and hands-on experience very early in your training. So obviously, learning neurosurgery is like going to the gym, right? You cannot do 100-pound deadlift on your first time of workout. You really have to build those muscles. So this is why you start very early with very basic procedures, mostly bedside procedures in the ICU, and slowly you're gaining more confidence to do more and more procedures. And there is an escalation ladder. You're not going to do an awake craniotomy on your first year, but you are going to do all those little procedures to, gain confidence and competence. And this is why I think that uh, it's like building a muscle. You start slow. How someone best approach a physician? There is no right or wrong way. Gunshot to 1,000 people, I'm sure one will say yes. This is my strategy. What resources, sites? Well, basically, Google is a pretty good resource. Whatever you want to learn more about neurosurgery, just Google. There are very famous websites for residents. One of them is Neurosurgery Atlas, which I highly recommend, showing both pathology, anatomy, and surgical videos. And YouTube is a pretty good one. Does neurosurgeon in the USA usually make 3D version of patient's brain? Well, I think that it depends on the surgeon and on the case, but it definitely happens.
Yeah. Oh, it's beautiful.
Do you believe that route to becoming Tirth Patel asks, do you feel that the route to becoming a neurosurgeon is a lonely road? Definitely not. I cannot do anything by myself except taking exams. I cannot do anything by myself. I think it's a team effort. Both the resident group need to support each other throughout this very tiring marathon, and also your family and the structure at home is crucial, at least in my opinion, to your success. Thank you guys. I'm reading the notes. This is very nice of you. Thank you so much. yeah, this dream is attainable to anybody. I wasn't cut from, nobody was cut from a different cloth. If I made it, all of you can make it. It's not,
And we're live in
I wasn't the
5,
smartest
4,
students in
3,
school.
2.
1.
All right, a good question by Talal Ismail. How difficult was it to maintain a work-life balance, different stages in your career? Was it worse as a student, and how did you or how would you suggest to manage it? So, yeah, work-life balance is something challenging in your residency. I spend most of my time in the hospital, so not too much balance there. But I think it's not about the quantity. It's mostly the quality of time you spend at home with your family, with your friends, and things that you like to do. I think that the more fields of interest you have outside of work, the better person and better doctor you'll be. If you like to play the guitar, if you like to read books, if you like to go out sailing, continue to do this. This will for sure make you a better man, better person, and a better surgeon. And those are the things that kept me motivated and the head above my, above water during those difficult times, is to pursue my personal interests, like surfing, going to the beach, diving. Those are the things that really helped me to and kept me on my feet on those very hard times during training. Is to engage in extracurricular activities as much as you can. And as I said, it's not the quantity, it's the quality of time you're doing that. Okay, good question by Celine Fathelbab. From Fathelbab. I'm sorry if I'm pronouncing it wrong. As an IMG, how was your diverse culture upbringing helped you as a neurosurgeon, and how was this helped you to give back to your home? It's a great question. So I really think that the more you travel, I think the more you see the world, the more well-rounded you are. I do think that all those different experiences around the world, and my upbringing shaped the way I am today. The way it helps me as a neurosurgeon is just the way it helps me as a person. I think that patients can relate to me, and I can relate to a variety of patients just by speaking different languages, by visiting different places in the world, and just by meeting a lot of people from all over. And I think that the more diverse you are as an IMG, actually can not only set the stage but set you apart. So by being someone that is more well-rounded and us, as IMGs, I think can stand out because we have very wide range of reference experiences, and I definitely think it shaped the way I am right now and helped me as a neurosurgeon. And I can see it on a daily basis that I see patients that are so curious and so interested to know more about my background and my versatile education career and training career, and I think that it makes you more attainable. And in my opinion, you don't want to be this neurosurgeon that people are afraid or don't want to talk to or feel too intimidated. I think that you should be part of the team, and the patients are on your team, and you really need their trust. And to gain that trust, you just need to be humble and be yourself and be relatable and and yeah. So I think all those things helped me a lot and shaped how I see or view life today. All right, Juliette Geens. Thank you. Your journey has inspired me to study abroad. The advice on finding mentor and support team is something no one has told me yet, and I appreciate it so much. I like the quotes on the slides. They reassure that other people get the struggle and strengthen us to keep working. Thank you. Thank you so much, Juliette. This is really making my day. If if I can be a living example that anybody can do it, that's the message I would like to convey. Tamara Tango asked me, have you experienced failure during your residency? Well, multiple times. Let me tell you, I wrote resignation letters at least 9 times during my residency. I did had multiple discussions with my colleagues and family and mentors saying this is too hard for me. And thankfully and luckily, they were pushing me um, um, very hard in those difficult times. And the fact that you have a shoulder to go home and share your emotions and feelings really helped me to push through. And I think that our surrounding is our physical surrounding is one thing, but our spiritual surroundings, such as friends and family and colleagues and mentors, are the real true things that help us to overcome all those challenges. And I think that something that is relatable to football and sports and military and residency is camaraderie. And when you have good people on your team and good friends that you can really rely on during those difficult times, those are the people that will help you you know go through the suffering and manage challenges and failures. If you were studying medical school in abroad, could you do residency in the US? Definitely yes. The answer is yes. Sandy Aras asking, as an IMG, how was your path to neurosurgery residency? Did you do research years for clinical experience in the US first? Fifth year Cyprus, looking to apply for USA for nurses. So basically, as an IMG, you have to stand out, right? You really have to be the best, and you really have to be as good as, if not even better than your US counterpart. If you think about that, US neurosurgery is a very competitive field. A lot of people want, a lot of good people from the US medical students want to get into a residency in neurosurgery, and this is extremely competitive and hard. The top 1% will get in. If you want to be part of this top 1%, you have to work 7 times harder than the typical US graduate. Why is that? Why is that? First, because you have to interview along the best people in the country. Second, and the way to do it is to work 7 times harder, meaning that you have to have 7 times more papers, 7 times more rotations, 7 times more letter of recommendations, and much more support from US-based surgeons. So the way to do it is to spend a few years in the USA, do research, shadow chief residents and attendings in different institutions, and get those letters. And after you do that, find a place to do a research fellowship that you think will give you the foundation to publish, and also to go and give your talks around the world. And this is how you build your CV and gain a lot of scores when it comes to residency. This is the only way to do it. It's not easy, but it's doable. Yeah, never give up. Never give up. All right, I think that we're about to wrap it up. So if there are no more questions, thank you so much. Feel free to hit me up anytime on my Instagram account or LinkedIn, which I shared. I hope you will have that. Queen, if you can share that with the people, that would be great. And good luck to everyone. I think that you're doing an amazing job, and you should really celebrate this success of Brain Turns. If you think about it, there are how many people right now? Almost 200 people. So you're the 200 people, and each and every one of you is doing something that 99% of people do not do, uh, in their summer vacation. So where you spending this time and effort and listening to those talks and learning, you really, um, you're really doing something that your colleagues or friends might not doing. And this is takes me back to med school when all of my friends were celebrating and partying and going to vacations and traveling around the world. I was stuck in my room and studying medicine. It felt very annoying and depressing at times, but now I can only look back and say that all those sacrifice paid off. So it's a slow process, and you have to enjoy and love the grind, because life is about the grind and not about the peaks. Thank you so very much, Queen. Thank you, everybody, and hope to see you soon.